I'm Beth Howell. I'm going to start off, and and Connie and Jeff and Megan and I had talked about this, and we said, well, there's not as many of us as there are other people signed up for this, so I'm not sure we need to do breakout groups. I don't know that we're big enough to do that, so I think we just do a group of the whole, if that's okay with everybody. No reason to get complicated.
That sounds good.
Okay, especially with all the issues we've been having. So I'll go around and we'll introduce ourselves, and then if you guys can introduce yourselves, because I wasn't able to be on this morning. I'm Beth Howell. I'm an addiction psychiatrist, addiction medicine specialist. I work at HMHI and run the addiction psychiatry and addiction medicine fellowships at the U. And Connie.
So Connie Kitchens, and I work with Dr. Howell on this particular grant, a piece we're going to be telling you on this HRSA Addiction Fellows grant. And I'm her project manager and a co-I on that. And then I have been working at PARCA, the Program for Addiction Research, Clinical Care, and Knowledge at the university, but I'm transitioning out of that position. So.
Jeff and Megan?
So I'm Jeff Clark, and I'm an addiction psychiatry fellow, and looking forward to talking with you.
And I'm Megan Schwartz. I'm one of the HRSA Addiction Medicine Fellows. Nice to meet y'all.
And just so you know, the difference between the two fellowships is that Jeff trained in psychiatry first, and Megan trained in something other than psychiatry, which happens to be family medicine. And so she's an addiction medicine fellow, and Jeff is an addiction psych fellow. And that's the difference. So, and for the rest of you, I think I know some of you, but I know some of you, but I don't know all of you. So if you can introduce yourselves.
So I'm Linda Tyler. I'm serving as moderator today. I'm with the College of Pharmacy.
Okay. Jenny.
Jennifer Coombs. I'm a physician assistant. And for a number of years, I've been trying and successfully spearheading doing MAT waiver training with the physician assistant students. And I also have a great deal of connections with some of the physician assistants and the rotations that we do in tribal communities. So I'm not in addiction medicine, but I have been a champion.
Okay. Yes. Steve, and then Natalie.
I don't know any of you guys here, so I just thought it would be. My name is Steve Seidler. I work with Beth. And also with Jeff and Megan as one of the associate directors. This is a great program that we offer for the fellows and also for the whole Utah community. I'm just interested and excited just to be a part of this.
Hi, my name is Natalie Allen. I'm actually a dual certified family and pediatric nurse practitioner. I currently serve on a ECHO hub committee in conjunction with Utah State for supporting children of the opioid epidemic for my pediatric role. And I'm also a registered Lakota Sioux member. And so I thought that this would be a great place. I know none of you. So anyway, there we go.
All right. Well, welcome. And so if we say anything dumb about tribal issues, you can definitely chime in, because we don't purport to be experts, but we would like to share some of what we've done. So let's, without any further ado, we're trying to talk today about our learning objectives and get to some of the cultural and community issues that impact designing effective health professional education, just in general in rural, tribal, and underserved communities, but especially about addiction. And I think some of the addiction issues will come up a little bit more in the discussion. Compare what we know in our academic and urban area with those with what we need to know to work effectively in different communities and construct effective ways to build relationships. And so we're going to share some of what we've done. And let's see, am I able to share my screen, Linda? Yeah, you need to let me. So this is who we are. and we've already done our introduction, so you know who we are. And here's us again, our titles. And the agenda we thought about would be, if we had a bigger group, like I said, we would do breakouts. But after the introduction, we're going to do a short presentation, and hopefully most of it is going to be photographs. Some of it is words, and then we're going to talk about some of the just kind of frame a case discussion. And we have a case that is from several years ago, but it is a real situation, and that I hope will bring up some discussion. And then we have really 45 minutes because we are not going to break up into small groups. So what we thought we would focus on today is the needs, the challenges, the assets, and the cultural differences in the rural, tribal, and underserved areas in Utah. And we're going to mainly focus on the rural and tribal areas, as opposed to looking at underserved programs in urban areas, because I think we have plenty of attention for those programs and those people who need our help. And then work on effective relationship building. And also we can talk some about how we get grant funding to expand treatment training and staff recruitment. So as you all know, we have a big problem with substance use disorders, and we, for many years, were one of the top 5 states in the U.S. for opioid overdose deaths, until the past few years when those rates started to go down, probably because of a number of factors. And we do see that methamphetamine use is rising, and also fentanyl use, which is often in either heroin or cocaine or other drugs. And one of the things that's interesting about our state is that we really focus a lot up here on the opioid epidemic, but there's certain parts of the state where that's not really the main problem, and the common drugs that are used really vary by the area. Treatment access is really limited, even when people are insured or have Medicaid or Medicare. Few physicians and other healthcare professionals are trained in the care for substance use disorders. And Jenny mentioned the MAT training, which is training in prescribing buprenorphine, which is one aspect. But if that's the only tool you have, you're not going to be able to treat a lot of addiction because people use other drugs or they don't want to take medication and that kind of thing. But it's a very important tool. And stigma, and when you get outside of Salt Lake, you're looking mostly at a system with primary care providers who don't want those people, quote unquote, in their practice. And I often will quote a provider in a small town in Southeast Utah who said, "If I find out somebody in my practice is addicted, I just discharge them from my practice." And I'm thinking, and where do they go? Because you're the only game in the area. So, but that's not an uncommon attitude that we see for our patients who have addiction. And so just to go over a little bit about what we do at Huntsman Mental Health Institute, many of you are probably familiar with this, but we have clinical care. We have a lot of levels of care for addiction, inpatient, outpatient, intensive outpatient, and we have an outpatient recovery clinic that started in 2006. And then in 2021, this past January, we started an addiction consult service over at the main hospital. We educate a bunch of different people, obviously medical students. We have a general psych residency. We have a triple board residency, child and adolescent fellowship, and we have addiction psych and addiction medicine fellowships. We also educate plenty of other nursing students, sometimes PA students, but really and truly in the last few years, we are overwhelmed with learners. And sometimes there are many more learners on a team than is comfortable for our patients. So we really need more sites and options for places to do education. In 2020, we were awarded this HRSA Addiction Medicine Fellowship Grant. It's a 5-year grant to expand the number of positions for addiction psychiatry or addiction medicine. And we have 2 HRSA slots in each of the fellowships. We also do some clinical research in addiction with our NIDA Clinical Trials Network. And then the other things we have been doing more of in the last probably 10 years or maybe 5 to 7 years is interfacing more with primary care and the community clinics, doing a primary care addiction care integration in the intensive outpatient clinic. And then in starting in 2015, but really and truly before that, a couple of our faculty members had traveled to Blanding and to the border with Arizona to work with rural and tribal partners, not so much with addiction, more with psychiatry, and especially child psychiatry. We started telepsychiatry in 2016, and then in 2019 started a project with the emergency department at the U to start people on buprenorphine in the ER and then bridge them with some clinic visits and then get them referred to the community. So let's focus on the rural health and aspects of this. And starting in 2015, we started at what was UNI at the time, working with some partners on what we call the Southeast Utah Addiction Medicine Coalition. And the way this started, there was one provider in Southeast Utah who was prescribing buprenorphine, and he was not really well trained in doing that. He wasn't an addiction specialist, and he was becoming overwhelmed. And he was asking for help to the point that he said, if I don't get some help, I'm not going to do this anymore. And he had a whole bunch of patients. And so that kind of got everybody's attention. And we said, well, we can do telemedicine, we can do consults. And they're like, we don't want more telemedicine. We want or need in-person help. We want you to come down here and see what we're dealing with. So we, a group of us went down in February of 2015, and we had many conversations and got to know the community somewhat. And then some of the health entities decided to put money towards having us consult with them. And so starting in 2016, January, Paula Cook and I started going down to Southeast Utah every month, and we would alternate months and go down for a week and spend time at several different sites. Now, this was before we started working in Carbon County in Price, so we weren't there at the time. And the psychiatry residents, we had a fellow who went down with us once or twice, but the psychiatry residents said, whoa, we don't get to see any of this. Our psych residency, with all the changes in Salt Lake County, has basically lost its access to underserved populations. And so they wanted to see what we were doing. And the Utah Medical Education Council, UMEC, paid for their travel and lodging and meals. As you know, we have a big state that we live in. Most of the population is centered around the Salt Lake Valley. And we have some very vast and sparsely populated parts of the state. And the 2 counties we were starting to work with were Grand and San Juan. And just to give you an idea, Grand County has a population at that point in 2016 of 9,429. San Juan, 15,000. And so it's 1.9 person per square mile in San Juan County. In the Navajo Nation, 6,068. And so this large area of our state represents about 1% of the total population of the state of Utah. Now, this is going to be a little bit misleading, but you can see that first county that turns red is Carbon County, and this is the rate of drug poisoning deaths per 100,000 population up to 2016. But you can see as you go from 1999 to 2016 that the poisoning deaths go up drastically throughout the state. San Juan County always has a lower rate, which I think is not accurate because when you have such a low population, you can't, a lot of times the data gets suppressed because if you say, well, we know a female who died on May 3rd of an overdose, you could probably name that person in a small area or an area with a small population. So I think many of these overdose deaths don't necessarily get reported because when I was writing a grant a few years ago, we couldn't get a lot of data that we needed in that area. The service area has a lot of challenges, and this includes Carbon, Emory, Grand, and San Juan counties. You can see that nationwide is the bottom blue line, and Utah is the one above it. And so Salt Lake County is green, but other state counties are usually much higher than the Utah or Salt Lake County rates for unemployment and health insurance, poverty, etc. And just to give you a little perspective, Shannon Took is a woman who works at San Juan Counseling Center in Blanding, and the population of Utah, this was probably several months ago, is about 3.16. San Juan County is now 15,000. It has gone up, but the poverty rate is about 2.5 to 3 times the rate in Utah. The Native American Indian population is almost 50% in San Juan County, as opposed to the rest of the state. The Hispanic population in San Juan County is actually lower than the statewide rates. Other ethnicities are about the same, and very, very few African American people. So just to pause for a minute and give you guys some time to just talk, how do you think these realities affect addiction and healthcare in these rural areas of Utah? And anybody can talk, you don't have to raise your hand or anything.
Well, I'm not sure if this is what you're going for, but I actually work for children with special healthcare needs, and one of my clinics is in San Juan County, and I actually have a care coordinator down there. And the realities of what's available for help is like, nothing that you didn't already tell us. It's just there's just not any support down there, and I see the same thing over and over, that providers down there just need our support. And I just always try to think, like, how can I ever affect this? And Beth, I don't know how I can. Like, I never know how I personally can improve resources. I've spent my whole life serving in underserved and rural communities, and I don't know the answer. I do not know how to fix it. All the passion in the world doesn't seem to fix it. I don't know.
That's a great comment. And I'm not looking for anything specific. I'm just trying to see what you either know about or what you think might be the case, considering, these realities that we've already talked about. What about others?
I'll add in, too, that just in the last month or so, talking with organizations in rural places, it's really hard as a physician to even put together a proposal to work there, because there isn't the money or the resources to support an FTE, and so oftentimes it is more piecemeal and trying to find a way to get somebody who's willing to put in a few hours here, and that doesn't give a lot of consistency or availability to patients as well. And so even when there's a desire to go in and try to help, it can be difficult.
Yeah, it's true.
Beth, I'm wondering too, if you're finding, I know initially you said they were reaching out for help and saying, we don't want telehealth. We want you to come down here and help us. I'm wondering, since COVID and the improved knowledge base among most people, the use of telehealth. Are you, is that somewhere that we really can? Because now people are more comfortable with it. They're more willing to try it. Insurance companies are more open to, reimbursing us. So I don't know. Are you seeing it? Like, that's a hope for me.
Yes, I think that everybody is a lot more comfortable with Zoom and telehealth. I think that we want something besides telehealth is not addressing the resistance to telehealth as much as it is, you need to see what things are like down here. You need to walk in our shoes. That's what I heard. So that's a whole different aspect of that. But yes, I think telehealth is so much more accepted now, and people are more comfortable with it. And actually, most of the providers I know in Southeast Utah, or at least, well, several of them, have really, really good telehealth capability. And so that's not even a barrier at this point, but it's not necessarily utilized. So, and I'm sort of asking you guys too, why do you, and I'll give you some examples as we go along about how things may not be utilized. What about others? Any other thoughts?
I can chime in a little bit. I did a rural rotation for a month in Monticello this last year as part of my residency. And I think the point about the in-person, not realizing what it's like till you're there, really rings true for me, because I look back now and I think I didn't realize that a lot of the patients that we saw, and even in the primary care setting, had to drive 2 or 3 hours sometimes to get to their appointments, or they were out in these rural areas and didn't, have the transportation to get in to see us. And if I was doing these appointments via telehealth, I don't know that I would recognize that, as much as, seeing the patients in person and talking to them. And, I might have suggested, come in every month to get your Suboxone refilled. And after being there, I just realized that maybe in-person appointments aren't as realistic as I might have thought had not been there.
Right. Well, let's go on and we'll talk more about these things, but there's lots of social determinants of health that I think we can discuss from these areas. One is, especially in a place like Moab, but even in other parts, there's poverty to extreme wealth. There's no public transportation. And like Megan said, people may have to drive if they have a car. If they have a car, do they have the money for gas? There are a few, places to get fuel down there in the areas. They're very far apart, gas stations. But many people don't have their own transportation. They may have to wait till a friend can bring them. The other thing that's a reality is that depending where you live, some of the roads are pretty inaccessible. They may not be plowed with snow. They may be completely impassable when they're wet, dirt roads, et cetera, et cetera. EMS, think about it. If you're in Salt Lake County or this Valley, if I call EMS, they're probably going to be at my house in, 2 to 5 minutes, maybe. If you call EMS, you would probably be dead before they could get there. If it's a real emergency, there can be tremendous delays if they can even get to your house. There are limited housing options, so it's not like there's tons of apartment complexes around. And if people are working in a very wealthy area, that let's say they're working at a hotel in Moab, they probably can't afford to live in Moab, so their driving to work is going to probably be at least 45 minutes to an hour each way to get to work. The job opportunities are very seasonal. They've been very limited with COVID. The Navajo tribal part completely shut down. I think it still is. And many of the Navajo people in Monument Valley made a good living with, giving tours and doing a lot of different things like that. selling their jewelry or other things that they make, and with fewer tourists, that's been a completely devastating hit to their finances. Long travel distances, I'll talk about that a little bit more in a minute. The other thing that I think we take for granted is cell phone reception and internet access. First time I went to the Monument Valley Clinic 6 years ago, I was like, what are all these trucks doing outside the clinic? And so people would drive to the clinic and they'd find out from their friends who worked there what the password was to internet, and they would do their whatever they needed to do on the internet, either with their phone or their computer while sitting out in the parking lot. Very few places to access cell phones. You might, it could be quite dangerous if you had a wreck or you were injured and you had no cell phone reception. If no one came along and found you, you would probably just die. It's also a food desert. A very limited availability of groceries. Much of the water is contaminated. There's some that's naturally contaminated and some that's been contaminated by mining and other extractive industries. But the food desert aspect of it, you basically need to take your own food if you're going to be living in Blanding or Monticello for a while, because there's maybe 1 or 2 restaurants in town and very little access to groceries. We talk about advising people to eat unprocessed food, but that's mostly what's available in the area. And on the Navajo Nation especially, but not just there, many people live without electricity or running water, and the unaffordable or unavailable housing. So this is just an illustration of some of that. About 60,000 are without electricity. This is focusing more on the Navajo Nation. 30% don't have running water. 40% have to haul water for everything: cleaning, cooking, giving water to their livestock if that's the way they make a living. Most houses are dry. They don't have running water in the more remote areas. And then internet service and cell I've already addressed. So just some of the travel times. The average time from these locations to a hospital one way, if we're talking about people going to the hospital in Blanding, which is Blue Mountain Hospital, it's 30 minutes to Bluff, it's 50 minutes to Montezuma Creek Clinic, 50 minutes to Mexican Hat, 65 minutes to Aneth or Mexican Water. These are in different directions. 90 minutes to Monument Valley. Often you'll be taken from Monument Valley, you might be taken down into Arizona. There's probably a closer hospital there. And from Blanding to Navajo Mountain, which I've never been to, is 3-hour drive each way. So the distances are vast. So distance, transportation, time, and money, these are some of the realities that have to be faced in Southeast Utah healthcare. So let's look at mental health and addiction more specifically. There's a high burden of mental health issues, including substance use and suicide. And accessibility to services is limited. There's not much availability, and acceptability is also a challenge of both. The workforce challenges are really significant. Recruiting staff, retaining staff, helping staff who want to do the work in the rural areas, and yet they find that through some little quirk they're not eligible for loan repayment, which is something they thought would help them with working there, accessing and providing mental health and substance use services. Everybody knows everybody else. You can't be anonymous in a small town. There's no way to really be anonymous in, say, a 12-step meeting. That's one nice thing about the pandemic. Now a lot of 12-step meetings are online. And so if you live down in Montezuma Creek and you have internet access and you want to go to an AA meeting in London, England, you can do that. So, there are some perks to the pandemic, but not very many. And exposing physicians to those areas and then recruiting them is really a challenge overall. And it's not just physicians; it's also physician assistants, nurse practitioners, RNs, case managers, social workers, you name it. Any kind of healthcare provider. It's tough. And then the loan repayment is challenging. So I'm going to show you a few of the places that we've gone, and this started in 2015. Try to go into some more of the positive stuff. We worked a lot with Moab Regional Hospital from the very beginning, and even it's a critical access hospital in Moab. It's a private nonprofit. And in the bottom picture, you'll see Four Corners Community Behavioral Health, the building that they've had in Moab. I don't know if they still have it, but they're trying to get a new building, but they don't have it yet. And they also have a free clinic in Moab. And most of the healthcare in Grand and San Juan counties happens in really three systems: the Moab Regional and Four Corners system, the San Juan Health Services, which is the hospital, San Juan Hospital and San Juan Clinic, which are connected to each other. And this is where Megan worked, I believe, right? Yeah. When you were down there for a month. And then also in Blanding, there's San Juan Health. There's Blue Mountain Hospital in the top left is the picture of the hospital. The Blanding Family Practice is run by Utah Navajo Health Systems. And then in the bottom right is the San Juan Counseling Center building, the new one. Utah Navajo Health Systems is a private nonprofit. They run 4 federally qualified health centers in the area: Blanding, Montezuma Creek, Monument Valley, and Navajo Mountain, which is the smallest. And these are pictures of some of the clinics and some of the views that you see there. UNHS is a really interesting organization. It's not the Indian Health Services, but they do provide services to Indian Health Service eligible recipients. They also take Medicare, Medicaid, private insurance, and so they have a broad funding base. So in this kind of atmosphere, we got awarded the 5-year HRSA grant that I spoke to you before about, and we added some more counties: Salt Lake, Carbon, and Emory. And what I would like to do is get our residents and fellows, mostly I'm focusing on fellows, educated about primary care addiction integration, interfacing with primary care providers, and exposing fellows and then residents, if they go along with us, to different communities and populations of patients that they may never see in residency or have rarely seen. And basically the point is to expose folks to many different cultures, risk factors, social determinants of health, etc. And so some of the things that we've learned about are how to provide services with few resources, how to educate about stigma in a small community, developing protocols. Sometimes we can advise on that, helping the programs understand what our standards of care are, and doing some teleconsultation. We can do telemedicine, but teleconsultation is also very important. So when we started out, these were the services that I've kind of gone over already. But if you talk about inpatient addiction services, the closest ones were in Grand Junction, Denver, Salt Lake, or Phoenix for inpatient addiction facilities. There's no inpatient detox. There was no residential treatment anywhere closer than that. And there was only one part-time psychiatrist who worked in Carbon County a few days a week. and we weren't even working with Carbon County at that point. Just the Four Corners Behavioral Health in Moab was providing medication without a physician until our residents started telemedicine there. And in San Juan Counseling, Steve Hyatt, who's an APRN, is the medical director and provider there. But he also works a little bit at UNHS because they don't have a psychiatrist or even anybody, a APRN who specializes in psychiatry or PA. So this is kind of what happened over the years. Price, Utah, Four Corners Behavioral Health opened an opioid treatment program in 2019. Moab Regional is building an outpatient addiction treatment facility. They got a SAMHSA grant to do that, and they plan to start a methadone clinic there also. Lauren Prest was one of our addiction psych fellows, and she went to Moab Regional in 2019 and has started doing some inpatient detox. Prior to that, the patients would have to be life flighted out to Grand Junction if they were having a complicated detox. Castleview in Price has started an inpatient detox service, and Moab Regional is trying to hire a second psychiatrist. And there's more telepsychiatry that we've been doing. So that's kind of how things have gone. And then I'll let Megan and Jeff talk a little bit about the only trip that they've been on so far, because next week we go to Moab and Blanding, has been to Price, to Carbon County. And like I said, in 2019, they started a methadone clinic. If you guys want to talk about your experience there and some of your impressions, that would be great.
So I think Megan has more experience, so I'll let her bat it in after I talk with my limited experience. So I have had very little exposure to rural health before starting this fellowship, and I'm still building on my experience. So I went to med school in Cleveland, Ohio, and residency in Seattle, Washington. Both moderate-sized cities, and have never lived in a rural environment either. And my interest for a long time has been in community mental health, which serves a different underserved population, but tends to be clustered more in cities. And I was just blown away by the dedication and inventiveness of the community mental health organizations, and really the people. Each person seemed like a linchpin in Price, somebody who had really come up with an impressive way to implement things without a lot of resources, oftentimes with pushback from other stakeholders in the county, including law enforcement and judges at times. And I just found it really inspiring and motivating, and really it led me to reach out to a lot of different people afterwards to try to talk about opportunities in a more resource sparse setting. And so I'm still new to figuring this out, but it's been a really cool experience to see how people function in a very different environment.
Yeah, you were pretty skeptical before you went down to Price. Yeah, I think you were surprised. Yeah. Megan, what about you? Because you've been to Monticello, you've been to Price.
Yeah, I think just going to these, I'm from North Dakota originally, so I feel like more used to how healthcare works in rural areas, but just seeing what they're able to do in these communities was really motivating. And I think actually being there as a learner and seeing it firsthand is like actually very inspiring. And so that would be one of the things that I would take away would be if, we want to grow these communities and help with resources, is to get people down there or, from the bigger cities and help people get involved so that they can see kind of the great things that are happening, and maybe decide to do that themselves in the future. So
Thanks. Yeah, Operation Recovery in Price may be one of the only, if not the only, rural methadone program that I'm aware of. And one of the things that Connie, you might want to talk with about our interface with some of these other organizations in Moab and in Price and Blanding.
Yeah, it's been really interesting. We took the lead of people in those communities that have been doing some of the work, Dr. Preston Moab, and then Four Corners in Price, to see who to connect with and where to do some interaction. So we've actually met with a variety of interesting groups. Here we're showing you Moab Solutions, who cleans up a lot of the homeless camps and parkways. And actually, just to talk to her right before this started, making plans for our trip next week, and unfortunately found out that one of the gentlemen we had met last year had passed away this winter, one of the homeless gentlemen. The Moab Valley Multicultural Center works with a wide variety of clients, a lot of Latinx. And so last year, one of our fellows is Latinx and was able to do some really fun work with them and do some training. So when our fellows actually go to these communities, they are involved in a lot of different ways with the community in these places, not just at the hospital or at the treatment center. So we've partnered with the jail in Moab as well. In Price, one thing that was really interesting that both Megan and Jeff got to do was go out on a harm reduction trip with the health department and do needle exchange. And they are one of the only health departments in the country, or I think maybe the only health department in the country that is certified as a harm reduction site. So a lot of really fascinating places. And I think one thing I want to add really quick is Dr. Howell and I actually went down in May to do some additional networking. And what we found is, even though these communities are small and you would think everyone knows each other, we really have had an opportunity to bridge partnerships. People are kind of doing their own thing. And in a big city, we kind of see that more, but it was kind of surprising in the small towns that's happening. And so we were able to help bring some people together that can do some cool work. So that's been really satisfying.
Yeah, it has been. And like in the upper left, that was a naloxone training that was being done. So another one of our big partners is USARA, which is Utah Support Advocates for Recovery Awareness. And they have staff in Price and in Moab. And I think they're going to get somebody in Blanding. And these are peer support people. These are people in recovery who are trying to just be supportive. And they're trained, they're paraprofessionally trained to help decrease the stigma and get people to treatment and, kind of bridge that gap between the medical system and the person out there who's got addiction and is not sure they want to get help. So the other things we did in Moab, that's on the left, we're meeting with the jail commander. We're meeting with the homeless folks. I don't know if the guy that is deceased is in that picture, but we met with the Moab Free Clinic, and that's I'd be dead without this place is from the Moab Free Clinic. So every town has its own stuff, and these are our fellows from last year, and they're at Mealy Point. And then this was actually right before the COVID lockdown. I was down there with one of our residents, Julian, who's on the right, and he was getting ready to start doing telemedicine. And so we went out to visit a man who, had no running water and that sort of thing, but he also was running very low on wood and it was cold. And so we took him a load of firewood. Rick Hindy is at UNHS and he kind of, spearheaded that, and we all unloaded the wood, and then we went to a trading post and all that. And you can see the man's sheep that he was tending also. And that person has since died also. It's a hard life. And I'm standing on the Four Corners right there. So, and then when Connie and I went down in May, UNHS was having a women's health fair, and there was all kinds of stuff going on. So the clinics were, trying to educate the community, et cetera, et cetera. And they have a young person's project that you see on the right. And so there are a lot of things that are going on. And so, I mean, I hear what we're all thinking, wow, there's just so few resources. But I think that people who are from those areas look at the resources that they have and they can be very, very inventive about them. And there are some limits, but I think everybody's working on the solutions. Let's do the case because we're getting a little low on time, and hopefully this will bring up some stuff. And I asked Jeff and Megan to talk about the case. Any questions before we go on to that, or comments? Okay, well, let's go on, and I'll let you guys start. We're going to talk about William and Melanie. The names are different. I've changed some of the details.
Okay, so I'll start off. It's a little bit of a long case, but if anything comes up, just interrupt me. But William is a Navajo man in his 30s who comes to see you urgently for her evaluation of injuries sustained in a fight with his wife. His physical injuries are minor, and he is reassured after your physical exam and x-rays. He did not call the police about the fight and managed the conflict himself. The Navajo police force covers the entire 27,000 plus square miles of the Navajo Nation and cannot respond quickly. Plus, William was drinking that night and was worried he'd be arrested. He confides that he lives with his wife and 3 children, ages 4 years, 2 years, and 6 months old. His wife, Melanie, thinks that outside people are watching through their windows and talking about them. She gets angry when William does not hear or see the outside people. This led to the recent fight. He is very worried about her and doesn't know what to do. Do you want to do the next slide, Jeff?
Absolutely. William says that Melanie smokes drugs at times. He heard about it from his family who live nearby. He's not sure what or how much she uses since he works and is not with her all the time. He denies that she drinks alcohol. Her biological father had an alcohol use disorder and she despises alcohol. She completed residential drug treatment several years ago and was abstinent when she met William, but he found evidence that she was using drugs shortly after the birth of their 2-year-old child. Melanie thinks nothing is wrong with her and that the people and voices are real. She refuses to come to the nearby clinic for care, including postpartum care for herself and their baby who is breastfeeding.
You decide to make a home visit. Melanie, William, and their 3 children are living in a storage shed with no running water or toilet. A local church is allowing them to live in the storage shed since they were evicted after Melanie's fight with William's family. The pastor's wife pulls you aside before you go in and says that people bring things to Melanie when William is at work. She's worried about Melanie's mental health, which seems to be deteriorating. William has built a loft in the storage shed for the 2 older children, and he and Melanie sleep below with the baby. The windows are covered with aluminum foil because of Melanie's fears of being watched at night. They have electricity run by extension cord from a nearby building and are allowed to use the church facilities only during the day. The shed is warmed by space heaters. Water and non-perishable food are stored inside along with the family's belongings.
Melanie agrees to be interviewed. She is holding the 6-month-old baby and appears depressed, withdrawn, and angry. She will not discuss the fight with her husband, but on questioning endorses that she hears voices and sees faces outside the windows at night. She will not say how long this has been going on. She believes these people are real people who want to harm her. She thinks her husband knows about them and is lying to her. She does not trust him and is indifferent about whether he goes or stays. She denies any thoughts of harming herself or her children. She denies any use of drugs recently or in the past. She denies ever being in drug treatment as reported by her husband. She says her main problem is the people who want to hurt her and her husband's collusion with them.
Okay. So these are some of the questions we came up with, and we thought it might be nice to just discuss, and you can discuss the case or you can just discuss anything that we really brought up already. But one would be, how would you supervise or mentor a learner seeing this family? Your student calls you up and says, "You're never going to believe what I saw today," and how would you mentor them? How would you give care to these people, and what differs in the rural tribal setting versus an urban setting? So, I'm gonna open it up and see if anybody has any thoughts. Even Jeff and Megan and Connie, because you guys have never seen this patient. Do you want me to call on somebody?
Beth.
Yeah.
So, I mean, I know that one of the residents has a family that's very similar to this that you and I have been kind of supervising. And so I don't know if this is that same case, but when that resident has been facilitating it to us, a lot of it has been trying to help the residents understand a lot of the cultural issues, trying to help them navigate the complex family dynamics, helping the resident tap into like the Utah Navajo's health sources right there to see if they can help broker communication that may just seem to be odd at the moment. And so there's a number of things like that that I know that I've tried to do. And I believe just since if this is based on the case who I think it is, you've been doing as well.
It may be. I did see this patient a few years later, so I don't know if she's still in the system or not.
I don't have experience with adults so much in this area, but I deal with families and children and similar situations, and I'm just going to throw out there that I feel like the first thing I would have to help a mentor or a learner is that this family, you've got to start with building trust, and it's going to take little tiny baby steps to get very far. Like initially there's just got to be some trust built, because trying to tackle all the rest of it until that's there isn't going to help.
Yeah. And just getting back to the firewood delivery part, some of the things that you do or that I have found that make a difference in an area are things that we probably wouldn't normally do in psychiatry. Like I wouldn't take stuff to a patient at their home, but my patients can get to see me, or they have internet or electricity or something, and they can see me that way. And I think that, if I'm not mistaken, I think when we went to see this family, that we actually took them something, and I can't remember what it was. Maybe something to eat, or some water, or so. It wasn't anything really super expensive, but it was like a good faith gift, so to speak. And I think those kind of things go a long way in this kind of situation. But building trust, and you have someone who's paranoid, which makes it even harder to build trust. What about safety? And this is probably something more like Jeff or Steve or I would think of as far as safety. We have a woman who's postpartum and who is paranoid, and one of the things that I would think of as postpartum psychosis, and does she need to be in the hospital? Is her baby safe? Things like that. And one of the things that actually comes up, because this family was living on the land, the reservation land, is that our Utah or Arizona or whichever state they happen to be sitting in, laws for commitment don't apply on the reservation. They're null and void. So, and that's one thing I learned from this particular case too. The only way you can commit somebody involuntarily is luring them off the reservation so that you can do that. And that's obviously not a way to build trust. So that our hands are kind of tied with some of the things that I certainly think of as an urban psychiatrist. Linda, any thoughts?
I think one thing when people are going into these areas, especially if they've not grown up in small rural communities, is, and it's sort of the same advice we'd give from an equity, diversity, and inclusion standpoint, is you have to be really open that all your assumptions may not be true, and you kind of have to label your thoughts about it, because it's really easy to say, "Oh, how horrible this is," and go racing in, and it's like, no, 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 because that's not what this family needs. That's not the kind of support they need. And it's stronger partnerships with others in the community. I mean, you think you can do it yourself. You can't. You have to work with the other community resources, and you're just coming in. So you have to think about both how to fix the acute problem, but what long term looks like, and what are going to be the resources for them. And it may or may not be you just coming into the setting. And I think that's one of the things is, people are, the level of suspicion that a family like this would have, even without the mental health issues of somebody coming from the big city. Uh, I see people really, really underestimate that.
Yeah, there's a cultural lack of humility that we all bring to situations like this, because
Yeah.
frankly, this might be a better place for them to live than when they were living with our family. It might
Mhm.
be a warmer and better, safer place. We're horrified, because it's not a regular home or whatever, but it might be an improvement. Um, Everybody looked pretty happy except for the patient. She didn't look too happy. What do you think would help learners understand what's available and facilitate access? What do you think would be important to do in this kind of situation? Because I think Linda's already talked about what might learners not know about the unique culture. We're coming with our preconceived notions.
I can say what was helpful to me when I've been doing rotations and things is sometimes when you come across these, just sitting down with a provider who is there to talk about available resources and just, ask questions. Even, I mean, when I was in Monticello, I was surprised that a lot of the folks down there had like helicopter insurance, because if they had to use the EMS services, a lot of times that was the method of transportation versus taking a regular ambulance. And so just, I think even when we're starting a rotation or down there newly for the first time, just being able to sit down with somebody who's in the community to talk about some of the things that are available can be really helpful.
Well, and I
So
would
one
say
thing,
kind of another thing is in communities like this. So I'm a pharmacist. We have lots of laws and are very prescribed in our practice in some ways. But in communities like this, everybody just rolls up their sleeves and does what needs to be done. And so somebody by title that you wouldn't think would have anything to do with this is actually the person that's doing it. So it's again, don't make assumptions about who's doing what in terms of what your resources are. Just, kind of go low and go slow, meet people, figure out what you've got. And it may not be the people that you're thinking of. And I know some of the pharmacists that have practiced in Blanding, they're like, this is what I do when I care for a diabetes patient. And it's a little bit of kind of everything. Um, and they've very much had to learn how the family dynamics work and how, where the beliefs are and how they dovetail into that. So sometimes your resource going in as a learner may be somebody that you wouldn't naturally by discipline think about would be able to help.
exactly. And, do they have refrigeration? Is it, just simple
Yeah.
things like that? The one other thing that I think of for pharmacy, especially when we first started prescribing buprenorphine for some patients and getting some of the
Yeah.
UNHS providers to get their bup waiver, is that, we had some employees of UNHS who were on buprenorphine. They didn't want to go to the UNHS pharmacy to get their
Yeah.
meds because
Yeah.
that's the people they worked with. So they wanted to go to another pharmacy. And there's really only like one pharmacy in
Yeah.
Monticello and one in,
Yeah.
there is one in Blanding that's not UNHS, I
We
believe.
we recently did actually a research study. The graduate student was interested in finding out how far did people have to go to get buprenorphine? Were there buprenorphine providers? And even during the conduct of a study, and he would have been doing it like, I think he was planning it in 18, but it would have been in 1920. So sort of some of the time frame that you were starting to work down there, is pharmacies would close in a community. Clearly, it'd be 70 miles, but it's not 70 miles on a freeway. People
Yeah.
people don't understand that either, and so some of that is just all challenging. But the ability to get more waivers is huge. But then some of the pharmacists described there were providers that didn't want to get waivers, and just huge differences. Surprisingly, we didn't find pharmacists who didn't want to stock buprenorphine and who didn't want to work with these patients. For the most part, they'd be happy to serve their patients in their community. And we were thinking there would be more disparity than there was. So, yeah.
Well, that's good to hear. Yeah. And even within Moab, there's really two pharmacies.
Right.
So, there's not a whole lot of, you think of Moab as being a more urban, but it's not really,
No.
area. And when we worked in Moab, some patients would say, I'm not going to go to City Market. I'm going to go to the other one. And,
Right.
and some of that, I know Lauren Prest, since she's been down there, she's done a lot of work with the pharmacies in the two main pharmacies to help with the stigmatization, because that's really
Yeah.
what the patients were responding to,
Right.
was the stigmatization. And then the other issue was funding, because it might be a lot more expensive at one pharmacy than another, but then you might have to drive. If you went to a cheaper pharmacy, you'd have to drive 70 miles and you didn't have the money to do that. So
Right.
it's not like going down the street around here.
Well, and it's acute, just like it is in many other disciplines. It's very, very hard to get people. This is why pharmacies in rural communities are oftentimes going belly up. They don't have. It's hard to get providers. You have no relief. Getting a relief pharmacist down there is extremely challenging. And so you're seeing this consolidation, and it's hard to get people to go in and train.
Yeah. Yeah. So it's not just, we always think about our own, like either physician or PA or NP, whatever, we think of our own profession, but I got to learn a lot more about the pharmacy and pharmacist impact on addiction treatment in Southeast Utah when we were down there back in 2016. And there were some great pharmacists and some others that, really needed to learn more about stuff. What about, Connie,
Well,
you down there? We're about out of time, but any
I was
last?
going to say we're getting close to time, and we want to honor everybody's time. So I want to thank everybody on the panel. It's been a great discussion. And for me, it was great to hear about the things you're doing in working with these communities and working with the patients who obviously are in great need, and benefit from your services. And as you've pointed out, you just have to be there. You have to see it in order to know how best to develop services and how best to care for patients.
Yeah, I agree. And that, nothing compares to being on site. So I'm going to stop sharing and see if there are any other last minute questions. I think we ended up with our same small group, which was good. We lost a person or two, but that's okay. And thanks everybody for participating. And
Well,
Natalie,
and thanks to all.
questions for us? You know how to get in touch with us. Okay.
Thank you again. This was really enlightening.
It does my heart good to hear. I work in every one of those. I work in Moab, Blanding, Price. I feel like children with special health care needs, we found a lot of success when we finally started hiring local care coordinators. We used to have care coordinators that just came from Salt Lake. They were located in Salt Lake. And it's been 2.5, almost 3 years ago. So we have a care coordinator. Well, she does Moab and Price because, but then Richfield and Blanding. And the success we are finding because the care coordinators live among the people that we help has improved vastly. So I love to hear about this. I know I work 2 spectrums. I'm a nurse. I have interest in this whole thing, but thank you for what you do.
All right. Well, thanks everybody. Thanks for participating.